Hopefully you could call me doctor in a couple of years. So because of the way things are laid out, it's more comfortable if I sit. We're all among friends. If you have questions, you can interrupt me, but it's usually best if we save them for the end, so maybe jot them down. I brought a lot of material with me. I want to talk about the role of MRI and how it relates to prostate cancer detection. I want to talk about the role of MRI in treatment. I want to talk a little bit about tissue-based genomics. Tissue-based genomics. And a little bit about PET CT. So we'll get through what we can, and we'll stop where we need to stop, because I have about a 2.5, 3, 4, 5-hour drive ahead of me, depending on what's going on the highways. And I don't want to jeopardize my safety. So with that, let's get started. Where am I pointing this? At you?
No, right here.
There we go. I have nothing to disclose. We'll talk about the history of biopsy strategies, the evolution of multiparametric prostate MRI, technical aspects of MR-guided biopsies, the rationale for MR-guided laser focal therapy of prostate cancer. I will give you all an update on NCT 02243033, which is a phase 2 clinical trial. I think last time I presented here, we were still in phase 1. We didn't kill anybody in phase 1, which is good. Now we're looking at efficacy, and we just presented our 9-year results at the American Urological Association in Chicago 2 weeks ago. If we have time, I'll touch on tissue-based genomics and the research that we're doing there, and I'll also talk about fluciclovine F18, which is Axomin. I was out in the Lottie area and overheard some people talking about PSMA. There's a lot of new agents out there, so if we have time, we'll talk about that. This is a gubernatorial proclamation by Governor Scott Walker declaring June 4th, 2015 Prostate Cancer Awareness Day in the state of Wisconsin. So as some of you know, I do a lot of advocacy work in addition to my research and my full-time job. I do a lot of advocacy work because, women, we get together, we talk about our childbirth, we talk about our mammograms, we're always talking about our breasts and our vaginas. And so I was at a meeting in San Diego about 7 years ago, and I made that comment, and I asked the guys in the room, what are you guys talking about when you get together? And this guy in the back of the room raised his hand. He goes, we're talking about your breasts and your vaginas. Wasn't exactly the answer I was looking for, but at least you're honest, right? So, let me see. Oh, I got a pointer. Okay. So I always say if it looks like a skunk and it smells like a skunk, it's probably a skunk. If we could see it, we could stick it. If we could stick it, we could run tests on it. Once we run the tests on it and we know what the heck it is, then we can treat it. Back in my early research, I did breast cancer product development and developed strategies to do in-bore MR-guided breast biopsy. And when that project was over, my GM asked me if I could do the same thing, just move it from up here to down there. And the role of prostate MRI has evolved quite a bit in the last decade. Now we can do really high resolution images, sufficient not only for detection and localization, but also for guidance for treatment. And this is just a table kind of describing the evolution of prostate biopsy in the literature. Back in the 1920s, what they would do is an incision in the crotch, the perineum, and poke around in there and take samples of what they felt and saw. Then they put a stainless steel straw down the urethra and palpated the back of the prostate and used a needle along the finger to sample the back of the gland. And then in the 60s, Watanabe-san and his team in Japan came up with the first clinically useful transrectal ultrasound images of the prostate. At that same time, McNeil et al. Had come up with the zonal lexicon for describing prostate geography. So whether a pathologist, a radiologist, surgeon, everybody's talking about the same place the same way. Then in the 80s, transducers got better. We were able to do intracavity imaging transrectally, which gave us good images of the prostate. A guy in Arizona named Dick Ablin, a PhD out of University of Arizona, developed the PSA test, and then Hodge et al. Came up with the sextant biopsy schema, which is taking 6 cores out of the right, 6 cores out of the left, and I call it poke and hope, because you don't know what you got. And then Stamey and Eskew said, well, if 6 is good, 18 is better, 24 is better, so instead of just taking the red, they take like the red and the blue, or the red and the green, or the red, the blue, and the green. But the problem is, what if it's here, what if it's here, what if it's here? You're gonna miss it. And that doesn't even take into account Z depth. So then came saturation biopsy, which is a transperineal mapping biopsy, where they take samples every 3 millimeters in the X and Y directions. But what if the guy's got an 80-gram prostate? You're only throwing the needle 1.8 centimeters into the gland. Anything that's deep, you're gonna miss. And this is what it looks like. So this is from my friend, Dr. Tom Palasic from Duke University. He's nice enough to share his slides with me. So I told a story at a meeting previously, but for those of you who've never heard it, it's kind of funny. So he chairs a meeting every year, a focal therapy meeting, about minimally invasive ablative therapies of kidney and prostate cancer. And about 12 years ago, 11 years ago, I got an invitation to this meeting, and I opened the brochure, and I saw he was the chair, and I'm like, that guy tried to kill me when I was 12. So I Googled him, and it was him. So I sent him an email, and it went something like this. Dear Tom, always wonder what happened to you after 7th grade. I see you became a urologist. Good job. It's been 36 years since you grabbed me by the ankle in the deep end of the Hillcrest Junior High School swimming pool during gym class and tried to drown me, but it's a good thing I don't hold a grudge. I'll see you at the meeting. So, needless to say, we are chummy now, and I don't feel threatened by him any longer. He went off to a school called Fairfield Prep in Fairfield, Connecticut, and I stayed in public school, so I didn't see him for a while. Anyway, so to do this biopsy that goes through the crotch, you can see this ultrasound monitor here. You see the reflection of the gloved hands of the operator and the transducer wand being put in the patient's rectum. This is the prostate. This white line here is the inferior wall of the urinary bladder. The black stuff is pee, and the white line is the needle going through the crotch and into the prostate. What are we getting a sample of? I don't know. Do you know? I don't know. And it looks like this for poor Mr. Man. You know, ABC 1, 2, 3. I sunk your battleship, and you end up with this. And maybe we could dim the lights a little bit so we could see things better, because we're going to get to some black and white images here in a little bit, and I want them to look clear. So when people start moaning about the cost of MRI, I talk about the cost of pathology, the cost of blind biopsy, and I don't just mean the monetary cost. Every month, I could tell you, I see at least a dozen guys that have come in saying, yeah, I'm on active surveillance for 3+3, they picked up with a trust biopsy, my PSA's going up, just want to know what's going on. So we do the MRI, and lo and behold, there's this large lesion that was missed at trust biopsy, and the guy's got higher grade disease than anybody thought, and often they'll present with extracapsular extension. So this is a big concern for me. It's not just the monetary cost of all this pathology, but it's also the emotional and physical cost to the patient. So each of these is $200 to $300 to put under the microscope. So that's a very expensive pathologic examination. And I liken it to this. You know, good news, the exploratory surgery turned up negative. So in the 2000s, a group in Charité Berlin took some beta equipment that we delivered there to do the first in-bore MR-guided biopsies transrectally. It's so simple. You look at the gland, you see the thing that looks funny, you stick a needle guide in the rectum, you take a picture, you aim at the thing that looks funny, and you take a piece of it. Gosh, I'm not even smart, and that makes sense to me. In the breast, we don't do blind biopsy. In the brain, we don't do blind biopsy. In the lung, we don't do blind biopsy. But men have quietly accepted this to guide their biopsy instead of this. So back in 2009, the National Comprehensive Cancer Network guidelines were pretty much bad test after bad test after bad test, and if the test is negative, repeat the bad test. So you end up in this cycle of bad tests. Then in 2012, the phrase multiparametric MRI was mentioned for the first time. And that followed the ESUR prostate MR guidelines, so that's the European Society for Urogenital Radiology. And the American College of Radiology came up with the PIRADS classifications. PIRADS 5 is super scary, PIRADS 1 is don't worry, PIRADS 2 is don't worry, PIRADS 3 is let's look at the prior probability of disease. In other words, does he have a family member who has prostate cancer? Is he African American? That'll tip you from a 3 to a 4. A 4 is, looks really funny. 5 is peek and shriek. Oh my God, that looks frightening. So I've asked the committee to do me a favor, do everyone a favor, and take this language and change it and make it action-oriented. Instead of making it diagnostic language, like saying, oh, 1 is probably benign. You can't say that. Looking at an image, you can't say something's benign, and you can't say something's malignant. Only a biopsy can tell you that. So it should say, highly recommend biopsy. Probably should have biopsy. Indeterminate. Probably doesn't need biopsy. Doesn't need biopsy. That's just my humble opinion. I've raised it like 6 times. We'll see if it ever changes. So here's some MRI images. There are different sequences that look at anatomy. There are other sequences that look at function. So anatomically, we could see the transition zone here, central gland, peripheral zone, rectum. All same slice, same anatomy. This is where the tumor is. It's dark on this sequence and bright on this sequence. This is called a diffusion-weighted sequence. Those of you who took a lot of science in high school and college probably heard about Albert Einstein in the miracle year, where he talked about Brownian motion. We have water cells or water molecules in our body that move between cells, and in healthy tissue, they move freely. But when you have infection, inflammation, or malignancy, they're compact and they don't move. The water doesn't move as freely, and we can see it visually on the image. We can also quantify it with a number called an apparent diffusion coefficient. And there's an inverse linear relationship between apparent diffusion coefficient value and aggressiveness of disease, which I'll show you in a second. And when you have your MRI and they inject contrast, the goal there is to see these curves, these pharmacokinetic curves, to determine is there fast wash in and wash out, which is suspicious for malignancy, or is it just kind of a slow, steady rise in a plateau, which is more kind of like infection and benign tissue. So we can look at that also and quantify it. And we have fancy schmancy software that lets us make pretty pictures and do segmentation and calculate gland volume, all that fancy stuff. And the other thing that's important when we do the MR image, when we get the gland volume, what we can then do is calculate PSA density. Dr. Swunjaristos did a great job describing the role of PSA density as a prognostic indicator. So, take your PSA, whatever it is, take your gland volume, and divide your PSA by your gland volume. That is your PSA density. So if we take a guy with a prostate the size of an apricot, and we take a guy with a prostate the size of a grapefruit, and they both have a PSA of 4, the guy with the apricot-sized prostate is going to have a higher PSA density than the grapefruit guy by virtue of the small size of his gland. So this is a very useful prognostic indicator. And we look at 0.15 as kind of starting to make us nervous. Anything above 0.375, we won't take a patient in our focal therapy study because that's, I'm not going to say dangerously high, but the likelihood of extracapsular spread is greatly increased the higher the PSA density. So then fast forward to 2016, the NCCN comes out with this language. Multiparametric MRI prior to biopsy may maximize the detection of high-grade cancer and minimize the detection of low-risk disease. I mean, how logical. And the team in Nijmegen did a great study back over a decade ago talking about the combination of the T2-weighted sequence, the diffusion sequence, and the dynamic contrast that I just showed you. And the accuracy gives us a receiver operating curve, area under the curve, of 91%. That's a really good test. When you consider that trust biopsy misclassifies cancer 47% of the time, 91% is really good. But wait, what do they say? Oh my God, you're missing things 9% of the time. Well, I'd rather miss it 9% of the time instead of 47% of the time. Then Yale reproduced those results and came up with a 96.2% accuracy. And in qualified hands, this is very, very reproducible. Now, when I was at the AUA, some urologist got up and stood at the podium and said, whoa, we're really worried because MRI can miss clinically significant cancer like 38% of the time. And I think to myself, where? At what institution? And please, can I come there and teach you guys how to make it better? Because that's ridiculous to have a miss rate like that. So a moment ago, I was talking about this inverse linear relationship between apparent diffusion coefficient value and Gleason score. So this on our machine would be 1240. That's high, and that's only 3 plus 3. That's great. This on our machine would be, God, I can't see that. Is that 0.59? No.
It's 0.99.
Oh, so that would be 990 on our machine, and you see the Gleason scores going up, and it's also darker. And then this is
0.66.
660 on our machine, really dark, 4 plus 5. So as a general rule, the higher the ADC, the less aggressive the cancer. The lower the ADC, the more aggressive the cancer. So that's just one piece of the puzzle. And so when we do the biopsy, where's a logical place for us to take the specimen from? The lowest ADC part of the suspicious looking area. So there it is, and there it is, and there it is again. Now, when we do the aiming to take the specimen, if I move this cursor just a couple voxels, notice the ADC here is over 1,000, the ADC here is 691. That's where we want the tissue from, not there. Because if I'm going to do the work of getting Gleason score and doing genomics, I don't want to take it willy-nilly. I want to take it from the place that looks the worst. So the other issues with trust biopsy, and I'm not here to bash trust. I think it's, it was good when it was all we had, but it's not all we have anymore. So the biggest problem is guys harboring clinically significant disease with a very aggressive component, and you miss the thing completely. See it all day. Other problem, picking up inconsequential stuff like prostatitis or something benign when he's harboring aggressive disease. Or skimming the edge of the thing and not getting the worst part, because then you undergrade, right? So the team in Nijmegen, and this is one of the reasons why I chose to do my PhD here, because so much good research comes out of Nijmegen, and they are leading prostate cancer researchers on the globe. So it's a privilege to be in the program there. So what Dr. Tom Hamrock did back in 2010 is he compared Gleason scores and results comparing 10-core biopsy to MR-guided biopsy, and clearly for Gleason 7 and higher, MRI far outperforms transrectal ultrasound-guided biopsy. So that's really important. And here's a number of papers that we published. This one was kind of on our own. We had some contributors. This was with UCLA, and this was with the Mayo Clinic. So we may be a little bitty outpatient imaging center in the desert, but Dr. Feller knows what he's doing. And he won't tell you this. I brag on him all the time because he's so smart. Graduated #1 in his class in metallurgical engineering at Notre Dame, which is part of the reason I worked with him for years in device development when I was with industry. And then, unsurprisingly, he graduated #1 in his class at the Ohio State Medical School. Then went on to graduate #1 in his class at Stanford for residency and was a professor of radiology at Stanford for 15 years. So he's no dummy. The biopsy itself is super easy. The patient lays on his tummy. We put a little needle guide smaller than my finger in the rectum, put coils over him and under him, take some pictures, look at a computer. Computer tells us how far to angle in every direction. and then we use the software to adjust the locks on the hardware so that we can angle to whatever direction we need to have the needle go right through the tumor suspicious region. And that's what it looks like. And when the tissue comes out, it's about the caliber of angel hair pasta, and it's usually around 1.8 centimeters in length. And it comes out of the tip of the biopsy gun, goes into formalin, goes off to the lab, they cut and stain it, and then we get a photomicrograph. So our reports are very elegant, and on the first page, you don't have to page through a 7-page report and read a long narrative just to find the single sentence that tells you what the heck is going on. I tell our pathologists we want red writing talking about the worst of the worst. We want a table that describes the length of the core, the percent cancer involvement, and the type of cancer. We want a photomicrograph demonstrating the type of cancer, and we want a JPEG of the MR image demonstrating the needle in the thrown position going through the tumor. So in a court of law, it's indisputable where that sample came from. So Gleason scoring is like skill sorting. For those of you that aren't familiar with it, 1 and 2 don't even get talked about. The lowest Gleason score that gets described by pathologists is 3+3, so that's intermediate. And, that's low grade, but on the scale, that's like right in the middle. Number 4 is higher, and number 5 is highest. So you could have a 3+3, 3+4, 4+3, 4+4, 4+5, 5+4, 5+5, 3+5, 5+3. They don't talk about 1 and 2. So a guy can come in, and the way it's done is the primary Gleason grade is added to the secondary Gleason grade, and the sum is the Gleason score. And then the score gets a grade. So it's really confusing to patients, all the language that gets used. So the primary Gleason score, primary Gleason grade, is the thing that there's the most of under the microscope when the pathologist looks at it. So for example, mostly Gleason 3, okay. Then what there's next most of is the secondary score, grade, and then that gets added to the first, and that's the score. So primary 3, secondary 4, equal to 7. If another guy comes in and the primary grade is 4 and the secondary grade is 3, the score is also 7, but he has a worse prognosis because the 4 pattern is the most dominant. Does that make sense?
Yeah.
Okay. Then, to make things worse, now the International Society of Urogenital Pathologists has come up with a grading system where 3+3 is grade 1, 3+4 is grade 2, 4+3 is grade 3, 4+4 is grade 4, 4+5 and higher is grade 5. So try not to confuse the total score grade with the primary grade and secondary grade from which the score is derived. Does that make sense?
Could you do that again?
Very confusing.
Yeah.
So specimen goes under the microscope, they look at what's there the most of, and in our example, there's mostly 3 and some 4. So primary grade is 3, secondary grade is 4, sum is 7, which is grade 2 ISUP. Make sense?
Yes.
Okay. So whatever your Gleason score, Gleason grade, there's a huge resource out there called the National Comprehensive Cancer Network. If you go to nccn.org and you go to their little search engine and you type in prostate cancer patient guidelines, you'll get a PDF of this document. Chapter 4 is Overview of Cancer Treatments. It's a really, really useful document, and I encourage everybody to take a peek at it. And the treatment stuff begins on page 31 and ends on page 48. So our clinical trial has been around since May of 2010. We're in our 9th year. It's a phase 2 study of laser interstitial thermal therapy for prostate cancer using MRI guidance in an outpatient setting with real-time MR thermometry. So just like the biopsy I showed you where we get the guy laying on his tummy and we pop the thing in his rectum, We use the MRI to aim and we take the sample. Exact same thing, exact same setup, but instead of putting in a biopsy gun, we put in an applicator that has an energy emitting tip. We deliver it through that same needle guide, and that's my finger. The thing is smaller than my finger. And we deliver it through a coaxial system. And then we use this visualization software to watch the images as we're cooking the tissue. So a lot of people don't understand that MRI can make pictures, but it can also create thermal maps. So we're able to watch the change in temperature over the course of time. So this device, this laser box, is FDA cleared. It's been since 2006. It's FDA cleared for soft tissue necrotization, not for cancer treatment. So we're using it in an experimental manner and combining it with a biopsy system to deliver the laser. This is another brand of laser that we use. It's called the Tranberg. It's made by a company out of Sweden called Clinical Laser Thermia. And this is their fiber inside a chicken breast. It was the first fiber I ever got from them, and before we ever use something on a human, we either use it in a chicken breast, a roast beef, or a pig liver. And I was able to kind of see what kind of energy I need to deliver a dose sufficient for soft tissue necrotization. So I have some choices of the instrument that I use. I can use a really strong laser that gives me a big burn, or I could use a cooled laser that has a smaller tip for a tiny burn if I'm looking at getting into a little nook and cranny. And this is the CLS team out of Massachusetts, Alan and Thomas. This is Dr. Feller, my medical director, and that's me with the fiber. So everything that we do is at 1.5 Tesla. I have patients call me all the time saying, I need a T3 MRI. No, you don't. It's not T3, it's 3T for one thing. And the American College of Radiology has said that 1.5 Tesla and 3 Tesla are equally good for detection and localization of clinically significant prostate cancer. And the bottom line is, in the United States, around 71% of magnets are 1.5 Tesla. Only 10% are 3 Tesla. All the rest are less than 1.5 Tesla. The things that matter way more than field strength are the operator. If you have a monkey at the buttons, you're going to get bad images. The software, it's got to be modern, state-of-the-art, able to do high p-value diffusion, so we have nice ADC images. The choice of coil, high channel count surface coils are what we use, because believe it or not, many men have surgically absent rectums. So if somebody's marching around the planet saying you have to use an endorectal coil, what if the guy's got no rectum? You've got to develop a surface coil protocol that's as good or better than the endorectal coil protocol. And if you're going to do that anyway, you might as well just use a surface coil all the time. So patient preparation, nothing by mouth for 8 hours before the exam. We can give an injection of a medication that slows the gut activity down so the images aren't blurry. And then, of course, an expert interpreter. There aren't many John Fellers on the planet, not many Jürgen Futterers, but, you know, radiologists that have gone through fellowship training should know what they're doing and how to use PIRADS and how to interpret these studies and do patients a good service. The other reason that we use 1.5 Tesla is because all the instruments that we use, they're all metal, and the devices are RF radio frequency induction tested up to 1.5 Tesla, not beyond. So we prefer 1.5 T because we do beautiful images. It may take seconds longer than 3T, but look at this. This guy has a humongous gland. They've got the endorectal coil in there at 3 Tesla, and all you can see is the back part of the gland because the signal's just coming off this far. With a surface coil, we could see everything. This is the exact same patient, 2 different techniques. And I can do really crummy images at any field strength, but the fact of the matter is, any theoretical gain in scan time shortening that you might get with 3T, we can more than make up for by spending 7 to 10 extra seconds. And here's another 3T versus 1.5T. Same patient, 1.5T here. See 1.5T? 3T here. look how different, look how much better. So, and also, you aren't radiologists, but see this white band here? That's all motion. Anything that's bad at 1.5T is worse at 3T. That's why we don't like it. So what else can we get out of the MR signal? We can look at tissue contrast. We can quantify flow in vessels. We can look at perfusion. In other words, does a tumor take up MRI contrast? We can look at diffusion, which is that water movement I told you about earlier. And we can measure phase shifts. There are all kinds of fancy parameters on the scan console that we manipulate to be able to do these things. And there's some fancy math called RNS modeling, which is how we convert the MR signal into thermal mapping data. So we can get a nice little rainbow-colored thermal map over the tumor and have labels showing what the temperature is in degrees Celsius as we're burning the tissue. So this is what the interface looks like. I can see the thermal map. I have an anatomic image up there that shows me what we're burning as we burn it. We have a calculated image called an irreversible damage estimate that shows all the voxels in that slice that received a thermal dose of energy. So I can estimate how big the burn is going to be. And then there's a graph showing the change in temperature over the course of time. So what we could do is contour to what we want to kill and put little boundaries around what we don't want to hurt. So the rectal wall, the neurovascular bundles that are responsible for erection, the external urethral sphincter, which is the muscle that keeps you from having to wear a diaper. All those things we can protect by putting up these little safety boundaries over them, so if the temperature exceeds a preset threshold, the laser shuts off. This is something that I tweeted on April 5th of last year. This patient had undergone a prostatectomy, and he developed a recurrence in the prostate bed where the gland used to be. So here's a tumor, here's a hole. So we were able to burn that thing away. So the first thing we do is a little test dose. We put the temperature at something like 100 degrees Fahrenheit, like what you'd have with a bad cold. It's not enough heat to kill tissue, but it's enough heat for us to see the tip of the applicator. And then this is what the irreversible damage estimate looks like. These are the safety cursors that we put on to protect things. And so the first time I ever talked about this publicly was at the European Congress of Radiology in 2011. We did the first human being May 24th, 2010. And I had done the preclinical testing at MD Anderson on phantoms, dogs, and pigs. So here's a patient, Gleason score 3 + 4 = 7. Nicely see the tumor on MR. This is him after his ablation. So here's before, here's after. So see that nice hole that we put there? And there's a side view of it. So this image is slicing him like a loaf of bread, top to bottom. And this is a view from the side. So his rectum is back here, his belly button's here, this is the bladder, and this is the prostate, and this is the hole that we made. So he comes back at 6 months for his biopsy because we follow every patient. We're not a dump and run kind of site. We don't just do it and say good luck. We do it, and then we have the patient return at 6 months for imaging and biopsy, even if we see nothing. And this, we see no tumor there, but we do a biopsy anyway in the treatment site. So he had a negative 6-month biopsy. And then he came back at 1 year, 2 years, 3 years, and we watched him for 19 years after the 1 year imaging. Oops, hey, come back. Another great thing about laser is the transition zone between treated and untreated tissue. So this is burnt tissue, this is not burnt tissue, and this is a 1 millimeter distance between them. When we look at HIFU and cryo, we have a 5 to 10 millimeter transition between treated and untreated tissue. So who knows what's going on in this fluffy area here? We have a nice crisp margin on what we did, so we know everything in here is dead. So as of last quarter, we had done 146 patients. 123 of them were treatment naive. 23 of them had had prostatectomy, radiation, brachytherapy, thermotherapy with hormones, or other stuff. The number of lesions that we treated was 228. The reason why the number of patients and the number of lesions is different, because some men were treated multiple times, some men had multiple lesions, and some men had multiple lesions treated multiple times. And so you understand what the label salvage means. That's anybody who's been treated and it came back. So this is kind of small, but I'm going to walk you through it. The important part is most of our patients were in their 60s and 70s. We had some 40-somethings, some 50-somethings, and some 60-somethings. Oh, excuse me, some 80-somethings. Location, mostly in the peripheral zone, a bunch in the transition zone, and then we had central zone, seminal vesicle, bladder wall, and other areas. PSA went down on the order of 40%, 37% mean PSA decline 1 year post-treatment, and sexual function, urinary function, and psychological well-being all bounce back to baseline by 1 year. So even if there's a little bit of a dip in sexual function or urinary function, it comes back at 1 year. Again, this is small, but the important thing to look at is Gleason scores. I love it when I go online and I see people going, oh, those people at DMI, they cherry pick 3+3s, that's why they have such good results. No, they have no idea what we do, and they shouldn't be talking about it unless they've taken a tour. We do mostly Gleason 7s, and we do high volume Gleason 6s. If it's MR visible and it's large, there's a high likelihood that it has some 4 component to it that was likely undersampled, but we do offer focal therapy for high volume 3+3. This is a Kaplan-Meier curve showing 100% survival among our prostate cancer patients. Only 3 men in our study have passed away. 2 were malignant melanoma, and 1 was brain and lung mets from an unknown primary cancer. And what my biostatistician did was he compared pre-treatment PSA density to response to therapy. And in terms of 6-month post-treatment biopsy, pretty much every quarter it looks like anywhere between 18 and 20% of our men have a positive 6-month biopsy. When you look at prostatectomy and radiation, at 5 years, there's around a 30 to 35% recurrence rate. So we're actually doing pretty good. This is the treatment naive cohort. This is the salvage cohort, the guys that have had multiple treatments of other stuff before we ever laser them. So every now and then we'll get a guy who turns into what we call a whack-a-mole. We treat the site initially, and just as we treat it, 6 months later, 2 new things pop up. We smack those down, 6 months later, something new pops up, and the old stuff pops up. That's a patient that we don't want to dabble with. After we've done a couple treatments, we want to make sure that they go on to whole gland therapy. We haven't burned any bridges. You could still have radiation, you could still have brachy, you could still have prostatectomy, because we haven't done anything to necrotize tissue outside the gland. So in summary, the conclusions are that at 9 years, our data in over 100 men indicate outpatient MR-guided transrectal laser focal therapy is both safe and feasible. There was no statistically significant erectile dysfunction or incontinence. Favorable results for quality of life without eliminating the possibility of whole gland therapy or additional laser focal therapy in the patient's future was evident. Short-term and intermediate-term oncologic control is achievable over 75% of the time. Minimally invasive outpatient laser focal therapy of the prostate can be an attractive option for specific patient populations. We've got partial quadriplegic, we've got patients with clotting disorders, We've got patients that are very poor surgical candidates. We have an HIV positive limb to our study, so they're special patient populations who could really benefit from this minimally invasive technique. Dr. Feller likes to say nothing brings good results like follow-up, which is why we're watching our men for 20 years, or as long as we possibly can. What we're studying in phase 2 is rate of biochemical recurrence in the population, rate of metastatic disease, both lymph node and bone mets, and all causes of death. So what I'd like to see in 20 years, I don't know if I'll be alive when we publish the results, but I want to see, that 80-something or 90-something% of our focal therapy patients died of something other than prostate cancer, and that the rates of metastasis were very low. So there's an international multi-institutional phase 2 trial going on right now. I abbreviated our 5-year study to 5 years, I abbreviated our 20-year study to 5 years for the international multi-center one. So hopefully we'll have those results published in about 10 years. We have ongoing IRB approval for our clinical trial exploring tissue-based genomics for risk stratification. What does that mean? We're taking the MR-targeted biopsies that we use to get the Gleason score, sending them off for a 22-gene clinical panel, and with patient permission and informed consent, I run the whole human exome, 1.4 million genomes, on every man who will consent to it, so I can compare different populations and their genomic profiles. We have an IND submission completed for the FDA to do combined therapy. So we believe that laser is good, but laser plus something else might be even better. And that's how we'll get rid of that 18 to 20-something% positive biopsy rate. Time check. 7:52. I have 8 minutes left? Okay. I'll go fast. You've all seen these. Confirm MDX, Polaris, Decipher, Oncotech DX, Prostate Vision, yada, yada, yada. I've used them all. And I did a little matrix and documented the benefits and drawbacks of each test. And my early experience was with Prostate Vision, which is simply 2 genes, ERG and P10. 2 genes that are well-published cancer, prostate cancer, prognostic indicators. Decipher was a test that was used on whole mount prostate specimens. They would take the gland out of the body, slice it up, go to the tumor, extract RNA from it, and run this 22 gene panel that I do, and with the patient's permission, the 1.4 million whole human exome. So I went to the owner of the company about 5 years ago, and I'm like, dude, when are you going to do Decipher and biopsy cores? And he goes, never. And I said, why not? And he goes, because cores are garbage. They're random. Why would I run a $4,200 test on something that was taken randomly? I said, aha, what if I gave you gold? What if I gave you a specimen that went right through the tumor and it was, 20, 30, 40% tumor material? Is that enough material to extract RNA and give me a profile? He goes, let me think about it. So fast forward to February of 2016, he released Decipher for biopsy. So I went backward in my phase 1 study and asked all the guys who would consent to it to let me procure their pre-treatment biopsy cores and run the whole human exome on them. It was fascinating. So we'll go back and talk about ERG and P10 first, because that's what I first had experience with, because these other tests didn't exist. So a Prostate Vision score of 2 means there's no overexpression of ERG and that P10 is normal. Every man is born with 2 P10 alleles. And I like to do a bicycle analogy and talk about ERG overexpression is like instead of being on a calm backcountry road on your bike, you're going down a wild mountain trail. If you're missing one or the other P10 allele, you're missing the back brakes or the front brakes, or both. So the worst case scenario is overexpressing ERG and missing both P10 alleles. That's the worst profile. So a 4 is no ERG overexpression and missing just one P10. Also, a 4 could be overexpression, but both P10s intact. A 6 would be overexpression and missing just one, and a 9 would be overexpression and missing both. That's going down the Wild Mountain Trail with no brakes. Another scenario is not enough tissue material. So, the post-op decipher, they can still do that with surgery. We don't do that. We do decipher for biopsy. Oh, hey, come back. I was overzealous. So, with Decipher, what we could do is the 22 gene panel and then the 1.4 million marker. And I have some other special things I'm doing. And what it gives you is a scale, low risk, intermediate risk, or high risk. Very straightforward. And then I get a research use only report called the grid. And this is all well documented in the literature. It's been used in prostatectomy specimens for over a decade, and the predictive ability of this test is very high. And when I used it retrospectively on the men in phase 1, some of them had had ERG and P10, and I went back and I got their specimens and did Decipher. 67-year-old guy with 4+3 in the right peripheral zone, 2 negative trust biopsies, go figure. We picked it up with MR. PSA 8.3, he had laser in September 2015. After treatment, the PSA goes to something called the nadir. Your nadir is the lowest level it reaches after treatment. So he nadired at 0.5, which is really good. And then he had a negative 6-month biopsy. His Decipher score was very low, and his ERG and P10 score was low also. Here's another case, 66-year-old, 3+3, left peripheral zone, base, mid-gland level, multiple negative trust biopsies, go figure. This was a large volume 3+3. His PSA was only 2.1, but he had a family history. We did his laser in December. PSA didn't nadir. He actually had it go up a little bit, but not 2 full points, which would have made us kind of get worried. But because he had a low-risk Decipher score and an intermediate ERG and P10, he had a negative MR-guided biopsy. Then take a look at this guy, 76-year-old, 3+4, left peripheral zone, PSA 6.8 in March of 2014, nadired at 3.5, had a negative 6-month biopsy, but he's at like 0.7 and he's on the high risk end of things. MR-guided biopsy was positive later, at 2 years out, but because we're watching these guys, we can pick this up. We know when things change because we follow them. His PSA went to 6.1, he had recurrent 3+4 at 2 years post-treatment, so he got a retreatment. This is a sad case. This guy, we treated him, we diagnosed him in 2010, treated him the first time in 2011 when he was 55. At the age of 60, I created the slide when he was 60 years old, but at the time of his 3+3 in the right peripheral zone, he was only 55. Still very interested in intimate activity and loved his wife and wanted to keep her happy. PSA 5.4, laser, January 2011. He nadired at 4.1, but then his PSA bumped up to 6.3 in August of 2012. So we lasered him again. He nadired at 3.4. And then his PSA went back up again almost to 6 in January 2016. So we repeated it again. When I went back and did his Decipher, it was over 0.8. It was one of the highest Decipher profiles I had seen. He was overexpressing something called glutathione peroxidase. They call it GPX3, and it's a prostate cancer indicator as well as a colon cancer indicator. And had I had this result back in 2010, before we did his first treatment in 2011, I could have informed him that he had that overexpression, that he had a high-risk profile, that he might be a frequent flyer, and oh, by the way, go get a colonoscopy, because this is the only patient that's developed lymph node mets in our study, and it was due to his colorectal cancer. So Radke et al. Did a really good paper a couple years ago about transcriptome-wide analysis of MR image-targeted biopsy. This is about Decipher, it's about genomics. Bottom line is the target must be hit. You can't just throw cores out willy-nilly and hope to get some prognostic information that's of value, because these tumors are, we say, heterogeneous. In other words, the tumor might be shaped like a piece of popcorn, but the worst part isn't necessarily in the center. It could be at the edge, it could be at the bottom, it could be at the top. Using that ADC value and looking at the MRI and figuring out what the worst looking part is the only way to get meaningful genomic information. So about a year into my experiments with Decipher, I had about 105 guys that we had gone back and gotten the Decipher done on. 38 Gleason 6s, 33 Gleason 3 plus 4, 7, 24 4 plus 3, 7, and 10, 8 and higher. So I did a distribution of Decipher scores among that population of 105. And then what I did was I did the distribution by PSA level and correlated the Decipher score to the PSA. And what you'll notice is they're independent. So I've got low PSA, low Decipher. I've got high PSA, high Decipher. But I've also got high PSA, low Decipher. And I've also got low PSA, high Decipher. Very interesting to me. Oops. And then what I did was I did that same distribution by Gleason score. So here's a distribution of Deciphers among the 3 plus 3s, mostly low and intermediate and a couple highs. And then this is the distribution by PSA. Then I did it with the 3 plus 4s, same thing, mostly low and intermediate, handful of high. And you notice there's no logic with correlation to PSA. And then here's the 4 plus 3s, and there they are with PSA. And then here's the 8, 9s, and 10s, and they're everywhere. So the bottom line was most of our guys had low risk genomics, some had average risk, and about 17% had high risk. And none of this is a mystery. I think they should have named this test Crystal Ball, because I correlate clinical outcomes to Decipher score, and it's fascinating. In our population, these are the 4 genes that are most dominant, top outliers. I won't get into that. And then there's some molecular subtyping that we do. There's types of cells: basal, luminal, luminal A, luminal B, straight up adenocarcinoma, neuroendocrine small cell, triple negative, genes called ERG, ETS, and SPINK1, which are also well-known prostate cancer markers. And we could see what our population looks like in terms of these subtypes. Then when you compare us to a site in Florida and a site in Tennessee, this is what I call the black factor. So we look a lot like our Floridian partner, but the Tennessee group is enriched with African Americans. And look at how much more basal carcinoma they have than the white populations in Florida and California. Fascinating. Also look at the increased neuroendocrine differentiation among the black population. So I think there's a lot to be learned here. What we're going to do with this information, I'm not quite sure yet. But what I decided to do with our population was I identified 7 men who were responders to focal therapy. In other words, they had their treatment and they were more than 3 years out and had no imaging evidence of recurrence and had no biopsy evidence of recurrence. What I did was I matched them to age within 5 years, Gleason score, and zonal location of their tumor to 7 other men that looked just like them, but that were non-responders. In other words, at 6 months their biopsy was positive, their Gleason score was promoted, their tumor grew, they developed lymph node mets, or they developed bone mets. So 1 is matched with 8, 2 is matched with 9, 3 was matched with 10, and on and on. So I did grid signatures with the whole human exome, and what I discovered was in the responders, which is these 7 men under the light green line, they upregulated these 20 genes and pseudogenes, and they downregulated these 20 genes and pseudogenes. The non-responders, the guys who got promoted or grew bigger tumors or had mets, they downregulated these and they upregulated these, the exact opposite. So out of 1.4 million genomes, I was able to isolate these 40 and put it into a test that I nicknamed the ribbon. It's not a real thing, it's research right now, but I call it the ribbon because each patient is a column in this heat shock map. So if they're mostly pink on top and blue on the bottom, I could sleep at night knowing that we either did active surveillance or focal therapy. However, if they're mostly blue on top and mostly pink on the bottom, I'm going to have a serious conversation with them that, you know, this could be an indicator of potential recurrence down the road, potential whack-a-mole status, and maybe ultimately needing whole gland treatment if in fact focal therapy fails. So it's just going to be a different conversation with men that look like this. So unfortunately, I have a very small sample size. I have to find men that fail, number one. Then I have to find a guy that looks just like them in terms of age and other criteria in order for me to build this database out further. But that's part of what I'll be doing for my PhD. So what I learned was that, you know, genomics can be used to differentiate patients with adverse outcome. The genes that were differentially expressed in each population kind of jumped out at me. There was differences in immune and cell cycle signatures. The vast majority of our patients are low genomic risk, and our sample size was a limitation in the analysis. So my feeling about genomics has always been, it's not that it's ERG or P10 or SPINK1 or SPARKLE1. It's not any 1 or 20 or however many genes. It's about the symphony of aberrations that exist in every man's RNA. So you could have a simple symphony like Mozart Piano Sonata in C major, or you can have the Isle of the Dead kind of genomics. And these are the guys that I'm worried about, the ones with this bizarre symphony of aberrations that puts them in the high-risk genomic profile category. So I'm not going to go into PSMA or any other imaging. I just want to go to the last slide. Maybe you could get me there. You could just scroll down on the side.
Let me get back to big screen.
There we go.
You want me to scroll or?
You could go there and scroll it all the way down to the bottom, and then go to slideshow. Keep going. 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 Have you ever seen so many slides? Oh my gosh. Jeez, does she? Okay, now go to slideshow. And go to current slide.
Oop. Oh.
Should have been from the beginning. That's okay, hang on, here we go. Whee. Deja vu, I feel like I've been here before. God bless America. Forget it.
Here, let me see if I can jump to end. There.
I've had
Okay.
4
Now,
hand surgeries. That's perfect.
I'm
Okay.
gonna follow your instruction this time.
Okay. Yeah, I've had 4 hand surgeries on my right hand, so my writing is garbage. And
Tell me what you want.
oh yeah, so go to slideshow
Okay.
and don't touch anything. Just click slideshow. And then you want to go from current slide. So click this.
Okay.
There you go. Ta-da. Okay.
Did it?
So if you're interested in laser focal therapy, either in a treatment-naive setting or a salvage setting, we are recruiting patients, and we will be for at least another 8 to 10 years. So by the time our 1,000th patient hits 20-year follow-up, it'll be like the year 2038 or something ridiculous like that. I probably won't be around, but I'm backfilling myself to make sure that this gets published. The Decipher Genomic Resource Information Database, or GRID, that's the 1.4 million genome thing. If you're interested in an MR-guided biopsy to get GRID, let me know. And then I'm also using Axumin off-label for risk stratification for prostate cancer. Axumin today is FDA cleared for the purpose of recurrent prostate cancer. I'm using it off-label for staging exclusively in men with Gleason 3+4 or 4+3 who are considering entry into this trial, because it's a known fact that somewhere on the order of 3 to 5% of men on active surveillance actually have metastasis. Knowing that, if I have a guy that wants to go on focal therapy and he's Gleason 7, I have to ask myself, what are the chances that guy has lymph node or bone mets? I don't know from an MRI, because an MRI doesn't image the entire lymph chain and it doesn't image the entire skeleton. Prostate MRI is limited to the prostate, and it's not a bad thing. It does a great job imaging the prostate. That's what it's supposed to do. But when I do a brain MRI, I can't see the heart. When I do a breast MRI, I can't see the pelvis. So when we do a prostate MRI, you can't see the bones of the skull, the ribs, the femurs. You can't see that. So I think it's smart to do Axemin before focal therapy, because in this study, 30% of the men that I've done so far have a positive finding. Not to say that 30% have METs. 30% of them have something that has uptake that alters the course of their care and requires radiologic, pathologic correlation before we can do anything with them. So, in summary, if anybody has any questions, you can email me at bernadette.greenwood@desertmedicalimaging.com. I'm usually very good about answering email, not so good with the phone because I'm often with patients or in procedures. So thank you. Thank you for having me again. I hope everybody learned something this evening. And if we want to bring the lights up, time to wake up. Wakey, wakey, eggs and bakey. Any questions? Of course.
We didn't have we didn't pass the basket, so Steve, you want to?
Pass in the basket.
Yes.
Then we're going to get the questions.
It's a church, therefore we have to pass the
Take
basket.
collection.
So are you saying that normal prostate testing?
When
where
you say
come up
normal
with your-
prostate testing, you're
Yeah,
talking
you know,
about
just
PSA
the
and
blind,
trust
the
biopsy?
blind testing is really not that accurate, or
That's
that?
exactly what I'm saying.
Yeah. What?
Hold it so everyone can hear.
Because if you're saying that, which, I mean, this sounds like something that we all should be doing, and if you're with, say, Kaiser like I am, I don't think they offer imaging.
So we've met with Kaiser on a number of occasions. We've met with their executive team, and their position, from what I understand, is that unless they can reproduce it across all Kaisers all over the place, they're not going to do it. So that's what I've been informed. I can't talk about what another entity does or doesn't do, but you know, the technology is available. It's all over the world, and if one entity doesn't choose to do it or doesn't want to do it, that's sort of up to them.
So they wait for, you know, massive amount of evidence to where they can afford to buy the, is it more expensive to do this?
In the grand scheme of things, no, because what a group in the Netherlands, De Roij et al., published a cost-effectiveness paper in the European Journal of Urology about 7 years ago, talking about the savings. When you insert MRI in the beginning, not at the end,
Yeah.
you interrupt things. You get a better diagnosis, you get better staging, you put the patient on the right treatment path at the get-go. So all this horsing around with, you know, wrong results and progression and like, you know, I could throw chicken bones on the floor, I tell people, and tell you better what's going on than a blind biopsy. Yet some urologists swear by it. I'm not here to badmouth anybody or say they're bad or wrong or uneducated or anything like that. There's just tools in our arsenal that we could be using a little bit differently. And I served on a panel in Washington, D.C., was it? The woman on the U.S. Preventative Services Task Force who gave PSA a D rating back in the day was on the panel also, and audience members were demanding to know, why? And I said, PSA isn't the problem. The reaction to PSA and blind biopsy is the problem. Why aren't we giving trust biopsy a D rating or an F rating? I said, let's not argue about the superiority or inferiority of various tests. Let's talk about how do we do them together and in the right order. So the NCCN guidelines in 2016 were very clear that MRI before biopsy will maximize detection of the stuff we need to be worried about and minimize the detection of the distals that we're not going to do anything with anyway. How many in here have had an MRI? Okay, how many have had a trust biopsy? How many have had an MR-guided biopsy, either fusion or in-bore? Interesting. Yes?
Actually, that's
Good.
when you do, what's the treatment for cancer that's found in some of the lymph nodes?
Remember the NCCN guidelines that I put up earlier? Chapter 4 is treatment options. So there's chemotherapeutic agents, there's immunotherapies, there's all kinds of things medically available for that treatment. And you would probably go see either a radiation oncologist or a medical oncologist to have those conversations. And remember, I'm a clinician scientist. I am not a doctor and I can't give you guys medical advice. I can talk to you about what other patients in my protocol have experienced and what my experience is with the data.
What did you call that guideline?
NCCN, National Comprehensive Cancer Network, and it's www.nccn.org. And up in the right corner of the website, you'll see a search box. Just type in prostate cancer patient guidelines, and that 70-something page document will pop up. Okay.
I missed the first 10 minutes, so I wanted to ask you, this particular type of biopsy is still available in various locations, right?
Right, all over the world. I trained probably 200 doctors on the planet how to do it over the last 10 years.
Well, how would it be, would it give a greater definition to cell expression profiles? You're not talking about this specifically cancer then?
Yeah, so the Decipher test would do that. It would give a genomic profile.
Other questions?
He's asking for the website to,
www.n like November, C like Charlie, N like November.org.
thank you.
You're welcome.
Just curious, so for the people who have done other treatment, brachytherapy, external beam,
Radiation,
yeah,
IMRT,
are we eligible for this?
absolutely.
later?
If you have a recurrence and you can demonstrate that you don't have distant disease in the bones or the lymph nodes, you would be a good candidate for a salvage treatment.
What's the highest radiation? What's the highest Gleason score to give it?
10. This patient, yeah, there was him, and then there was another one who had, he had Proton, external beam, and brachy, and he had local recurrence of 4+3, bladder wall invasion of 4+4, and seminal vesicle invasion of 4+5. And we went in and debulked everything, and he died at the age of 88, so of something else. Yeah.
What's the physical location where this is performed?
Do you know where Indian Wells is? Are you familiar with the Pariba tennis tournament? Yeah, that's where we are, in Indian Wells. That's where the lab is. So when I do tours of our institution, I take people on the hot side of the house first, and I walk them through PET-CT, show them where the radionuclides are delivered, introduce them to our mascot, who's a blue brindle, show them the hot lab, show them the staging area. Then we walk through kind of the atrium of the office where the administrative staff is, and then I show them the ultrasound, the CT, the MRI, and then we walk down the research corridor where all the scientific posters that we've presented at national and international meetings are hung on the wall in chronological order, so you could see the progress of the research that we've done. And then we culminate in the recovery room where our latest AUA poster is hanging, and then we go into the research closet, and I open up all the research binders and show people that when the FDA walks through the door and says, I want to see the informed consent on patient number 47, I can produce that document both electronically and hard copy. And so you know, we have an external IRB. An IRB, it stands for Institutional Review Board. It's a committee of people that independently evaluate research for academic, scientific, and ethical rigor. So our studies are evaluated every year and they're renewed every year. And my biostatistician is a PhD out of Rutgers, so I don't run my own numbers. So nobody can say, oh, Bernadette's numbers are great, Dr. Feller's numbers are great, but Bernadette's, cooking the books. No. Dr. Rob Toth runs our numbers. Every quarter I get a report from him, and that's what I use and what Dr. Feller uses when we go to these meetings and we present our outcomes.
Any further questions?
Did you learn anything?
Yeah.
Did you have any fun?
How much does it cost for
It's
us?
very expensive. I do not have an R01 grant from the NCI. I do not have a DOD grant. I do not have a VA grant. I don't have anything. I have a patient that gave me a check for $250,000, and he said, this is so you can finish your research. So for a nanosecond, I thought about putting it in my bank account, but instead I formed a foundation. And so I was able to treat him and have funds to treat 9 other men who meet the financial burden of proof that they need it. So it's $25,000. So that's the reason why when, you look at access to trials like this, I wish I were a grant writer. I've taken a number of grant writing workshops, but there aren't enough hours in the day. To write a good grant takes like 4 months. It's like doing a dissertation. It's a lot of work. And not that I don't want to do it or can't do it, I don't have the time. So right now we're limited to men who can afford a $25,000 procedure, but the good news is it covers the treatment that day, 48-hour ultrasound of the bladder, 3-month surveys and follow-up, 6-month imaging and biopsy of the treatment area, 1-year imaging to compare to 6 months. And then after that, they go on active surveillance with insurance.
But to do that, you really should have at least a Gleason of 7 or above, right?
Or large volume 6. So as we sit here today, if I'm reading your mind, I'm telepathic, I'm thinking you're on active surveillance for 3+3.
You
If
got it.
you're my husband, or you're my brother, or you're my dad, I'm shipping you off to either Ross Schwartzberg at Scripps for an in-bore MR-guided biopsy, or John Feller for an in-bore MR-guided biopsy.
But I mean, there's a lot of other people that are 3.3 seems to be pretty common.
3+3 is very, very, very common.
Yeah.
But when it's taken blindly, how do you know that's what you have? Not here to light a fire under you or to cause concern. Sampling error is the biggest problem with trust biopsy. It terrifies me when I get a guy who comes in. I have one in my mind right now, and it's so maddening to me. He's walking in, he's like, yeah, my PSA is up, oh, it's probably BPH or prostatitis or whatever. I got 3+3, we've been watching it for 8 years, and his PSA is through the roof, and he's got bad cancer, really bad cancer, and he's been sitting on it for 8 years. I mean, there aren't many things in my job that make me want to cry, but that makes me want to cry. And to think of the years lost, to think of the time lost, to think of the opportunity lost. And I'm not here to peddle focal therapy or to convince anybody to do anything. That's not why I'm here. The NCCN guidelines are very, very helpful in directing patients and educating them about what's available, to who, and what are the side effects. It's a very, very well-written document. And to think, you know, a patient could be put on an active surveillance protocol when in fact they harbor higher grade disease and they miss an opportunity for curative therapy and they have a bad outcome, it's inexcusable in the year 2019. So,
Yeah.
What was that biopsy? You said something bore. What was that?
in bore. So inside the MRI scanner is a tunnel. That tunnel is called the bore. So we put the patient in, you missed this part, we put the patient in laying on their stomach, we insert a needle guide in their tail, and we use MR imaging to get the trajectory that we need to aim to get to the worst looking part.
So it's closed, it's closed open, right? With MRI.
MRI is not closed. Way back in the day, we would have to pull down something called a Faraday cage that controlled radio frequency going in and out. But they're all open. I mean, there's like open, you know, they're like 1 Tesla or 0.5 Tesla or 0.23 Tesla. Those are open. But ours is a tunnel and it's open at both ends. So,
Now, if that same patient had a multi-parametric MRI, would you feel with, you know, and it's read professionally and things look okay, would that be?
that would be very reassuring.
Okay.
That would be very reassuring. And in fact, there are a number of studies out of London. Mark Emberton, Hash Ahmed, Caroline Moore, Louise Dickinson, all did great work showing that 1.5 Tesla multi-parametric prostate MRI is a great screening tool. And in the UK and in Europe right now, there are no biopsies done without an MRI first. It's in the guideline.
Mm-hmm.
Well, but you can fight for it. This isn't
Don't get a
something...
biopsy.
Huh?
My public service announcement is don't get a biopsy.
Don't get a trust biopsy. Get an MRI first. Yeah, there's actually a study out called MRI first. So,
Well, I've had 2 of those, 2 trust biopsies.
and no MRI.
No MRI. But they're both blind, like you say.
Right.
But they both
So-
came up pretty much the same.
The missus has a little homework. I see she's writing her assignment.
If I might share just.
I'm going to hear about it in the car all the way home now.
Okay?
Steve?
Yes.
Well, you have to ask yourself, is $25,000 worth your life if you have $25,000?
No. The biopsy's not $25,000.